We'll move on to our next speaker, Dr. Wendy Woodward.
Okay, up next we have Dr. Wendy Woodward. Well, do you want to just go ahead without your introduction? I feel like we should take a second.
Go ahead.
Okay, yeah. So Dr. Woodward is going to update us on radiation oncology. She is a professor and the chief of the clinical breast radiotherapy service at the University of Texas MD Anderson Cancer Center. She received her MD from Jefferson Medical College and her PhD in biochemistry and molecular biology from Thomas Jefferson University. She completed an internship in internal medicine at Albert Einstein Medical Center, a residency in radiation oncology at the University of Texas MD Anderson Cancer Center, and a fellowship in mammary gland biology at Baylor College of Medicine. Dr. Woodward is currently a professor and the chief of clinical breast radiotherapy service in the Department of Radiation Oncology at the University of Texas MD Anderson Cancer Center. She is a physician scientist specializing in clinical breast radiation oncology with a lab focused on inflammatory breast cancer, the microenvironment, and breast cancer stem cell biology. She is deputy director of the MD Anderson Inflammatory Breast Cancer Clinic and Research Program. This program is dedicated to advancing the radiation treatment and biologic understanding of inflammatory breast cancer through laboratory, translational, and clinical research. Nationally, she serves as a liaison between the Breast Working Group and the Translational Research Program in the Radiation Therapy Oncology Group, devoted to designing translational endpoints for multi-institutional trials in breast radiation therapy. Specific interests of hers include studying the molecular determinants of treatment resistance in breast cancer stem cells and novel treatment of inflammatory breast cancer. Welcome, Dr. Woodward.
Thank you so much. So I'll go ahead and share screen. Here we go. So here are my conflicts. A moment to visit those. And that outline, there wasn't as much high impact platform presentation of radiotherapy at San Antonio this year as there have been in some years. So I was going to sneak in some local therapy. There was one axillary lymph node dissection randomized trial on the podium, SYNODAR 1. Talk about the 5-fraction debate, because I think that probably impacts us in practical ways and impacts patients today more than anything else. And a few of the local regional posters from the spotlight sessions. And then if there's time, I'll sneak in 2 probably higher impact radiation studies that were presented at ASTRO this year and were very interesting. And for sure, if I get close to time, Carmen, feel free to just raise your hand and I'll try to make sure we end on time. So this was the SYNODAR 1 study, which was comparing axillary lymph node dissection to sentinel lymph node biopsy in patients who have 1 to 2 positive sentinel lymph nodes. And their rationale was that there were limitations in the existing trial and that it was important to really complete a trial like this, understand what the group is. So these were their 2 arms. They randomized over 400 patients, axillary lymph node dissection versus sentinel lymph node biopsy. And you can appreciate the types of metastases. These were not micrometastases, which is an important distinction from the prior trial. And these were the results. There we go. These were the results. And you can see very few events in both arms, very equivalent events in both arms. All of the actuarial outcomes were also equivalent. No statistically significant difference in terms of survival or recurrence between the 2 groups. Axillary recurrence 1 in both arms, distant recurrence 7 versus 8. And the distinction in this trial, no micromets, 20% of these patients had mastectomy, which is different from the Z11 study, detailed radiation data. The follow-up is really only 3 years, so you could argue maybe a little bit more follow-up would be valuable, but the presenters have made the statement that they have changed their practice and will no longer be doing axillary lymph node dissection for patients who are eligible for this trial. So that's a confirmatory piece of data for that practice and was helpful. Probably the most interesting and highly attended radiation session of San Antonio was the 5-fraction debate. And so as you may know, for breast cancer decades ago, everyone had a mastectomy. For even small breast cancers. Big randomized trials demonstrated a lumpectomy and radiation was completely equivalent. and radiation for a very long time was 5 or 6 weeks to the whole breast. There have been beautiful randomized studies that demonstrate that you can do that in 3 to 4 weeks. It's just as safe and it works just as well. And right in the middle of the pandemic, in March of 2020, the UK published the UK Fast Forward study comparing the 3-week regimen to 1 week of whole breast radiation. And they have completely changed that to be the standard of care in the UK for all whole breast radiation. And so that was the debate. 1 week of whole breast radiation is the new standard of care. And Professor Coles from the University of Cambridge argued for, and Professor White from the Ohio State University argued against. Both are very renowned clinical trialists with a lot of experience in this space. So some common terms, because I know we have a diverse audience. Whole breast radiation, WBI, gray is the unit of dose for the radiation that we give. A fraction is a single treatment. F for fraction, dose per fraction is the dose in gray. That's the radiation dose we give per treatment. And the real discussion here is how much dose can you give per treatment and how fast in order to be safely delivering high quality and effective radiation. So Dr. Cole started. He basically pointed out that the hypothesis that had been tested here is that breast cancer is as sensitive to fraction size as late responding normal tissues. And if that's true, then going slowly with what's considered the small and standard fractionation of 2 gray per day is not providing any benefit to spare tumor or normal tissues equally, and that it would be worth it to test larger dose per fraction in clinical trials. The UK has a very impressive history of clinical trials in this space, moving from the left over here, the standard 50 gray and 25 fractions, 5 weeks of radiation. They conducted the START A and B studies, which were the ones that increased it a little bit more than 2 gray per fraction and got us to 3 to 4 weeks. They have now published a study called the FAST trial, which was a large fraction once a week over 5 fractions. And then they started in 2011 and ultimately published the Fast Forward trial that we're talking about today, which is a big fraction every day, 5 days, 1 week. And so that's where we are. These were technology-enabled trials. Things have changed a lot in radiotherapy over this time period. Looking at efficient delivery, these trials accrued very rapidly and make a massive difference in providing radiotherapy to people who currently do not have access. So this is the Fast Forward trial itself. Eligible patients were T1 to 3, node positive or negative. 4,000 patients accrued with a median follow-up of 6 years. And the 3 doses they looked at were the standard 40 gray and 15 fractions, so 3 weeks, and then 2 different dose levels in 5 fractions for 1 week, 26 and 27, which seemed surprisingly similar, but there were different results. And they were able to look at clinical assessment annually, photos, and patient-reported outcomes for a multitude of endpoints. So the first thing Dr. Coles pointed out is there is no hint that the efficacy is not as good. So in the blue line, we see the 5 fraction 26 gray, green 27 gray, the standard 40 and 15. Looking over here on the y-axis, you can see these are incredibly small numbers, and these were absolutely equivalent. Efficacy was fine. And so, sorry, I'm going to skip that one. For the cosmetic side effects, though, there are differences here. And so up at the top, we have the endpoints either favor the once a week 5 fractions, or they favor the 3 week 15 fractions. And in green is the 27 gray, 1 gray higher than 26 gray. And for overall adverse events, this favors 3 weeks. And that's true for breast distortion, shrinkage, induration, in and outside the tumor bed. As we get down here to 26 gray in 5 fractions, no difference for overall adverse events. We do see some breast induration outside the tumor bed and breast edema being slightly worse with the 1 week course. Dr. Coles highlighted over here the absolute percentages of these events are incredibly low. This was a very reasonable cosmetic outcome, even though it was slightly worse than the 3 week course. Now, there's several myths about why people say, well, we can't possibly adopt 1 week of radiation right now. And one is that the 5-year follow-up isn't long enough, and that if we waited for 10 years, we might see that these things get worse. So she highlighted the START trials, just looking at how parallel these lines are from 5 to 6 years, that we don't see differences, or 5 to 10 years, so we don't see differences in the 10-year outcomes, and it doesn't make sense to make patients wait 5 more years. And she highlighted the FAST data. This is where they compared 5 weeks to once a week for 5 weeks with 30 gray versus 28.5 gray per fraction. The first row is the 5-year data. The second row is the 10-year data. When we look at the hazard ratios for 30 versus 50, if anything, it gets less at 10 years. We look for 28.5 versus 50, very similar hazard ratios at 10 years. So she said, this is a myth. We shouldn't have to wait 10 years. What about subgroups? A lot of people have said, well, they're not represented for triple negative patients, HER2 positive patients, high grade patients, young patients. Certainly there are patients enrolled on these trials who represent these groups. You can see particularly for the triple negative groups, there are about 100 in each arm. And here are the forest plots for those subgroups, all largely favoring the 1 week fractionation. So these patients are not well represented, but there isn't a hint here that they're doing worse with 1 week of radiation. So this was the UK consensus, 26 gray and 5 fractions over 1 week, absolutely the standard for whole breast. The standard for chest wall radiation without regional nodal radiation, so just the chest wall alone, these patients were included in this trial, that this was largely the standard for patients who'd had reconstruction, although this really had not been tested in this study, and it was absolutely the standard for partial breast irradiation. So she concluded that the strong scientific rationale was proven, clinical trial results built on 3 decades of high quality data, and this should be rapidly implemented to benefit every patient globally. And Julia White took the opposite side. So she said, no, this is not the standard of care, and highlighted that the goals of breast conserving therapy are to secure in-breast control and to preserve cosmetic appearance. She appreciated that the UK has worked very hard and done outstanding work to really demonstrate that you can reduce the number of radiation treatments using the radiation biology that's been well studied over decades. And she also highlighted the timeline to be able to get through from 5 weeks of radiation to 3 weeks of radiation to the FAST trial, which does have 10-year data. But she highlighted the FAST trial to begin with, which is again, this 5 weeks versus 30 gray in 5 fractions, once a week over 5 weeks, or 28.5. She noted, as we see in the study we just presented, that the outcome in terms of ipsilateral breast tumor recurrence was the same. But again here, the slightly higher dose of 30 gray compared to 28.5 was associated with significantly worse cosmetic appearance. So no statistical difference in actual breast control outcome, but significantly more mild to marked changes in the breast appearance on photo, adverse effects, and the hazard ratio for marked breast change was 2.7 for the 30 gray choice. Here again, the actual adverse events here much higher for 30 gray compared to the other 2, although the in-breast recurrence is very low. And her main point here is that there's an incredibly small difference between 28.5 and 30, and suddenly you're looking at significant impacts on breast appearance. So looking at the UK fast forward trial, 3 weeks versus 1 week versus 1 week, 2 different dose levels. Again, non-inferior, no argument about the efficacy in terms of tumor control. But once again, an incredibly small difference in dose, 27 versus 26, takes this from being equivalent to having significantly worse cosmetic outcome. So her point was that yes, the goal is to secure in-breast control, but preserving cosmetic appearance and breast sensation is also a key element here, and that is really not accomplished by the 1 week fractionation. So here's the subgroup analysis for comparing the 3 weeks in red here on the right versus 1 week on the left. And even the authors argue that the hazard ratios and odds ratios indicate a trend in favor of the standard arm for most items. She also highlighted that one of our goals in modern radiation therapy is to really finesse the dose across the breast and to have really clear upper dose breast limits. 5% of the breast should receive no more than 105% of the dose. And really that difference between 26 and 27 gray is in that margin. So how often would you give someone 1 week of 26 gray and really end up in the 27 gray zone without careful planning? She also asked the question, how often do radiation oncologists follow their patients? And here's a SEER Medicare linked study It demonstrates that only about 4% of patients are still being seen by a radiation oncologist 5 years later. So if there is going to be significant cosmetic toxicity, it might not be appreciated. So she concluded by highlighting the importance of balancing benefits and risks. Nearly all the treatment decisions involve some trade-offs. The patient voice is incredibly critical, and it's important to have equipoise where we are. Lastly, she said, one size shouldn't fit all. At the end of the day, we have 10-year data for accelerated partial breast irradiation with fractionation schedules for 1 week that are incredibly well studied. We have multiple ongoing observation trials. There are great studies for concomitant boost for higher risk patients to get done in 3 weeks instead of 4. And really we should be personalizing care across this spectrum. For what it's worth, I would just highlight that in our own practice, we feel very comfortable with the 1 week 5 fraction course for all of the patients who might otherwise be eligible for APBI or observation, as long as they appreciate we have 5-year data and there are some measurable but small differences in cosmetic outcome. And of course, both were appreciative of all of the effort that has been done in these trials in order to provide patients more options. There was an audience poll before and after, and the question was a very standard luminal A postmenopausal ER positive T1N0 patient. Would you give that patient 5 fractions or 15 fractions? And to start the debate, 50% chose the 15 fraction regimen. And at the end of the debate, 80% would have chosen the 5 fraction regimen for that patient. So certainly there were some who were convinced by Dr. Cole's argument. A couple of posters from radiation that were highlighted in the spotlight session that I'll just go over from led by Dr. Strauss's group and Dr. Mola's group. The first one was just looking at the avoidance of RT for low-risk breast cancer. Of course, there's a CALGB randomized study highlighting that omitting radiation in women over 70 with luminal A breast cancers who are going to take tamoxifen is not associated with a difference in disease-free survival. There is a small difference in breast tumor recurrence. So they looked in a multi-hospital retrospective review at patients who met the low-risk criteria of the luminal trial for observation. And they looked specifically at endocrine adherence and how that impacted in breast tumor control. Over here, you can see the lumina eligibility criteria. And what they find is that, as had been seen before, omitting RT is associated with a small but measurable risk of in-breast recurrence. But it's interesting that that absolute number was notably lower in patients who met the definition for non-adherence to endocrine therapy. This wasn't statistically significant, but it does highlight that this warrants some additional study and consideration as we talk to patients about omission. Another study that was highlighted and scored well was this study, which is looking at the safety of doing repeat partial breast irradiation or repeat breast conserving surgery and radiation after an in-breast recurrence in a patient who has had previous lumpectomy and radiation. So this was a multi-institutional retrospective review, 35 patients, median age 65. These were by and large what appeared to be fairly favorable in-breast recurrences. They were small, 4 years out from their prior radiation, no significant radiation toxicity from the first treatment. And the outcomes were very good. There was no significant radiation toxicity that was presented. Ipsilateral breast tumor recurrence was pretty uncommon. 5-year regional free survival, 82%. Overall survival, 93%. The discussant put that into the context of the other salvage and lumpectomy partial breast reirradiation trials, and even really compared it to the RTOG phase 2 study, where we see really comparable results in these patients in terms of how this study was run, slightly less follow-up, but good ipsilateral breast tumor control and 5-year overall survival. And I think there is movement to try to explore this in a phase 3 study. There were a couple of other posters that looked interesting, and I've mostly highlighted these here in case you want to go back and see them. This is one looking at deep inspiration breath hold, which is a way to get the heart out of the field when you do radiation planning, and thinking about it for the right side as opposed to the left side as a way to get out of doing more advanced technology and needing less IMRT. So for those who are interested in that, that's maybe worth going back and taking a look at. And I've included a couple of other posters that also fall into that realm. This one looking at some of the correlations between radiation and fatigue. And then this one I'll spend a moment on, which is validation of a predictive signature for radiotherapy efficacy called POLAR, which has recently been purchased by a company that is looking to bring this to market, which I think is fantastic and will help radiation oncology begin to move into the realm where medical oncology has been for a decade. So this is a novel signature that had already been published. And here they were examining it in the randomized Princess Margaret trial of radiation versus no radiation. And I'll just highlight the main conclusion over here. The figure 1 versus figure 2 is that the patients with high risk scores benefit from radiation and the patients with low risk scores don't. So that really is a holy grail for radiotherapy that I think we're all hopeful will come into practice for us moving forward. It's good to see that validation. So then I'll just briefly tell you about some trials that came out at ASTRO that were provocative. First one on metastatic breast cancer SBRT, and then one on regional nodal irradiation. So the CURB trial was presented by Dr. Jillian Tsai at Memorial Sloan Kettering. This was a randomized trial looking at patients who had oligoprogressive disease, and it included both lung cancer and breast cancer. The primary endpoint was progression-free survival. And this is an interim analysis at 1 year after they've accrued 106 patients. You can see the randomization over here, no SBRT versus SBRT in combination with standard of care therapy. Here's the study timeline. The majority of the non-small cell patients are patients without driver mutations. 35% of the breast cancer patients had triple negative hormone status, and the median number of lesions that were treated was 2. Here are the different lesions that were irradiated, where they were located: spine, node, lung, standard sort of metastatic sites, no brain in this study. And the interesting, these are preliminary but provocative results, are that while there is an emerging significant, highly significant difference in progression-free survival for the trial overall, it is entirely driven by the lung patients. And so really highlights, I think, the importance of waiting for randomized studies in breast and thinking through the biology in breast and not getting too carried away with SBRT for oligometastatic or oligoprogressive disease in breast cancer outside of a trial. The breast cancer patients had a greater number of new lesions following oligoprogression as the first site of further progression, so it wasn't failure to control the primary. Overall, the SBRT was well tolerated and well performed. So progression-free survival benefit of SBRT was driven by the lung cancer cohort, so worth it to really pursue further studies for breast biology. And then the next one that I'll just mention is the regional nodal irradiation study CROG 0806. This is a randomized study. The schema is down here on the bottom right: node-positive breast cancer, mastectomy or breast-conserving treatment, no neoadjuvant chemotherapy. Patients were all receiving radiation, including the supraclavicular fossa, and then randomized to the internal mammary nodes. And they all got 45 to 50.4 gray, pretty standard treatments, pretty standard systemic therapies. The primary endpoint was disease-free survival, designed to detect a 10% difference in 7-year disease-free survival. 50% of the patients were breast conserving. It's important to note that there was an imbalance in the arms, so there were some more ER negative patients in the no IMC radiation group. And so that needs to be considered reviewing the multivariate analysis. The overall results was there were no difference in recurrence, disease-free survival, or overall survival. There is a numeric difference here when we look at breast cancer mortality in the internal mammary nodal irradiation group, but it wasn't statistically significant. But what's interesting about this study, and you may be aware that there have been multiple studies that have included medial or centrally located tumors that have demonstrated a benefit to regional nodal irradiation. And the early breast cancer trialist collaborative group meta-analysis highlights the significance of the central and medial located tumors in terms of the benefit of radiation. And in that setting, there is a significant benefit in disease-free survival to the internal mammary nodal radiation. So again, this is still somewhat early data, but I think adds a tool to our consideration about which patients should we be including internal mammary nodal radiation for, as we are, most of us, I think, doing more regional nodal irradiation after the publication of MA20 and EOR2C 22922. There was, as you might expect, more radiation pneumonitis in the internal mammary group, and there are certainly techniques and strategies that can be used to try to reduce this. Pretty even amounts of grade 1 and 9 grade 2, which is a symptomatic pneumonitis compared to the no IMN group. This is typically easily treated and self-limiting. So conclusions, including the internal mammary nodes for these node-positive patients didn't improve disease-free survival, but it might help for patients who have medial or centrally located tumors. But it's a limited study, and so that needs to be taken into consideration. So those were all of the recent updates that I found for radiotherapy, and we snuck in one local regional one for the sentinel lymph node trial. And I, of course, want to highlight that these are all slides that were presented by and made by other authors, and their contact for the San Antonio is on the bottom of those slides, and appreciate all of the patients and trialists and advocates who are involved in making all of that work happen. Yeah.
All right, thank you so much, Dr. Woodward. And I'd like to see if anyone has any questions that they'd like to ask Dr. Woodward. Feel free to either unmute yourselves or add those to the chat box. We do have a
I'm
comment.
always happy to answer questions too. If anybody ever wants to email me, more than happy to chat.
We do have a comment, Dr. Woodward. Just great discussion. Thank you. In the chat box.
Thank you.
All right. Well,
Have you all
seeing
seen
no
much
questions-
5-fraction radiation, whole breast radiation here yet, or still thinking about it? I feel like there's been really mixed uptake around the country.
It seems like something we're seeing used more in older people, people who live far away, people who kind of have reasons that maybe a longer treatment course isn't appropriate for them. But I don't see it being used as a standard approach yet. I don't know what anybody else's perspective is on that. Dr. Avery from Lincoln is saying kind of the same thing, poor uptake so far, but you're saying you guys are using it really as a standard approach for many patients, or it's something that you're offering those people? How do you approach that?
We offer it. I feel comfortable with it for patients who are well represented on the trial. So the postmenopausal luminal A low risk breast cancer patient, who really that is their preference, that understanding there's only 5 years of data and that maybe there might be more breast swelling that they'd rather, be done in a week. And there are certainly patients who are very happy to have that approach. And I even see some younger patients who would prefer to do that and are happy to move it forward. So I don't mind offering it and discussing it with patients. And I certainly think for partial breast irradiation candidates, if you can treat the whole breast in 5 days, you can certainly treat the partial breast in 5 days. And that's pretty appealing as an option for some patients too. So I wouldn't say it's our standard, but I would say that we have put it in the toolbox.
Are you using it in people who've had reconstruction?
We have
Or
not
over
really
implants?
ventured there yet.
Yeah. Okay.
And we don't do much chest wall alone radiation, so it doesn't come into play for us for chest wall at all.
All right. Well, thank you very much for putting the presentation together and taking the time to join us.
Thank you.